Namaskar, dear viewers. Welcome to today's session of Young India Intensivist webinars. And today the topic is massive hemoptysis, something we don't see commonly, but it can be quite a challenge to manage it when it does come. And we have a distinguished speaker today with us, Dr. Vivek Nangia, sir. Sir is Chief of Pulmonology, Cluster 1, Max Healthcare India. He is Vice Chairman and Head Institute of Respiratory Critical Care and Medicine at the Max Hospital SAKET Complex, New Delhi. He is also the recipient of several awards and fellowships and the Vice President of the Indian Association of Bronchology, amongst many other things. So thank you, sir, for being with us and doing this. And I look forward to a great session for everybody.
Yeah, thank you, Dr. Page, for bringing me in for such an important topic. Hemoptysis is something, if you see from the patient's perspective, it's very, very concerning to them. Even if there is a spot of blood that comes, patients get very hyper and very excited that, there is major thing that is happening to them because the first thing that comes to their mind is cancer. They can't seem to think beyond that. But actually, if you look at the causes of hemoptysis, there are a plethora of causes that could be causing hemoptysis, and also that it is just not the diagnosis, but we also need to manage the hemoptysis, especially if it is massive in nature. So, in fact, I'm not sure whether Dr. Tapesh was aware or not, but I've contributed a chapter on bronchoscopic management of hemoptysis in one of the textbooks, which, in fact, they're coming up with a newer edition also now very soon. So hemoptysis, if you actually see, has been known from ages. Hippocrates actually said that spitting of pus follows the spitting of blood, consumption follows the spitting of this, and death follows consumption. So this is basically referring to TB, because at that time TB was probably the most common cause of hemoptysis, or probably even other conditions could not have been diagnosed like lung cancer, bronchiectasis, so on and so forth. But if you go by definition, then hemoptysis is the spitting of blood derived from the lungs or bronchial tubes as a result of pulmonary or bronchial hemorrhage. So it is basically the blood coming out of the lungs or the bronchial tubes, that is the airways. So there are certain things that you need to be very careful when you're eliciting the history of a patient with hemoptysis. One is, does the patient have known pulmonary, cardiac, or renal diseases? Does the patient smoke? Is there a prior history of hemoptysis or any other pulmonary symptoms, or any symptoms that are suggestive of an infectious cause like tuberculosis? Is there a family history of hemoptysis, aneurysms in the brain, epistaxis, a GI or a skin rash? Has the patient been exposed to asbestosis or any other kind of occupational exposure? Is there an underlying bleeding disorder or a risk of DVT? Is the patient taking drugs? And now even vaping for that matter should be taken history of. And if the patient has had TB or been exposed to TB in the past or not. While examining such a patient, you should specifically look for telangiectasis, a skin rash which could be seen in infectoendocarditis, and these infectoendocarditis which actually we are associated with multiple small abscesses in the lungs. If there's any audible chest bruit or murmur that could be heard during inspiration, which actually refers to a large pulmonary AV malformation, presence of P2, TR or PR or RV lift, and heart murmurs which could suggest mitral stenosis or a congenital heart disease. So these are the things that you should look for in a patient who comes to you with hemoptysis. Is there any signs of DVT? Because DVT could result in pulmonary embolism, and pulmonary embolism in turn could also result in infarction and hemoptysis. What is more important is that you are able to differentiate between hemoptysis and pseudohemoptysis. Pseudohemoptysis basically refers to coming out of blood either from the upper respiratory tract up to the level of glottis, or a hematemesis that may be happening. So how do you differentiate? This actually takes me back to our undergraduate days, where this was a common question that was asked in the internal medicine examination, that how do you differentiate between hemoptysis and hematemesis, or hemoptysis with pseudohemoptysis? So it's very simple. When there's somebody with an upper GI tract bleed, usually they would manifest as a coffee colored bleed, would be associated with nausea, vomiting, with some kind of epigastric tenderness. They would usually have signs of chronic liver disease underlying. And if it is an upper respiratory, there could be bleeding gums, epistaxis, little or no cough, or sputum, or a sore throat. There would be evidence of gingivitis, telangiectasis, ulceration, varices of the tongue, nose, nasopharynx, oropharynx, or hypopharynx. So all this you'll have to, do just a local examination or just by detailed history, you'll be able to differentiate whether this is actually hemoptysis or a pseudohemoptysis. So if that is true hemoptysis, then it will usually be associated with cough, expectoration, and some other symptom related to chest, like chest pain, fever, uh, sputum, breathlessness. So you'll have to look for all these things in your history and also in examination. So when it comes to approach to hemoptysis, it basically comprises 5 steps. Sorry, there's something wrong with this slide. So basically, approach to hemoptysis would comprise determining the magnitude, then determining the cause of bleeding, the site of bleeding, then planning the intervention, and then the specific therapy. So these are the 5 steps that you need to perform in a patient who's come with hemoptysis. So first of all is the magnitude of bleeding. That means how much is the quantity of blood that the patient is bringing up. If it is streaks, then you don't really bother about it as much. You just try and identify the cause and then treat the cause, and these streaks would settle down. The problem comes is when it is massive or submassive kind of hemoptysis. So how do I take the history and tell the patients that if it is streaks, then don't worry, let's just get a CT scan done and we see what it is and then treat it accordingly. But if it is a cup full or a glass full, then that is something that you need to be worried about. We don't have any specific definition for severe hemoptysis. The definition varies from people to people, from region to region, but a 200 ml per hour in a patient with normal lung reserve is considered to be massive. 50 ml per hour in a patient with chronic respiratory failure, and any amount more than or equal to 600 ml per day is considered to be severe hemoptysis. So again, mild is less than 50 ml, moderate is 50 to 200 ml in 24 hours, severe or major is more than 200 ml, and massive is more than 600 ml. It's considered to be life-threatening if it is 200 ml per hour or 50 ml per hour with respiratory failure. By another definition, massive hemoptysis is considered to be up to 1000 ml, either more than 500 ml of expectorated blood over 24 hours or bleeding at a rate of more than 100 ml per hour, regardless of whether abnormal gas exchange or hemodynamic instability exists or not. So different people, different definitions, but majorly I feel anything above more than 500 ml in 24 hours or more than 50 to 100 ml per hour should be considered as significant hemoptysis requiring immediate care, because this can be associated with very high degree of mortality. Mortality is not only because of the volume of blood expectorated resulting in asphyxiation, but also because of the rate of bleeding resulting in exsanguination. The amount of blood retained within the lung could result in aspiration. So pre-morbid respiratory reserve is very, very important. The mortality rates vary according to the rate of blood loss. 58% mortality if it is 1 liter per 24 hours, 71% mortality if it is 600 ml in 4 hours, and 80% mortality if there's an underlying malignancy. So what are the indications for ICU admission? One, that you have to look at the etiology. If the etiology is associated with a very high risk of bleeding, like aspergillosis, lesions with pulmonary artery involvement, then there are chances that even after treatment or even after initial stabilization, the bleeding can recur. Then it's better to have them in the ICU. If the patient has any gas exchange abnormalities, like a respiratory rate of more than 30, oxygen saturation less than 88%, patient is requiring high flows of oxygen or is on the ventilator, then again, you should have an ICU admission. If there is hemodynamic instability, that is hemoglobin has dropped down to less than 8 grams, or there's a decrease of more than 2 grams per deciliter from baseline, if there's associated consumptive coagulopathy, hypotension requiring fluid bolus or vasopressors, if there's a massive hemoptysis more than 200 ml per 48 hours or more than 50 ml per hour with a chronic respiratory disease underlying, if there are respiratory comorbidities like a previous pneumonectomy, COPD, cystic fibrosis, or if there's any other comorbidity like ischemic heart disease, if the patient is on anticoagulants, then it's always better to have them in the ICU and manage them accordingly. There is another scale that you can use for predicting mortality and deciding where the patient should be admitted, whether in the ward or in the ICU. That is, if the chest radiograph is showing involvement of 2 or more quadrants, you give them 1 point. If the patient is alcoholic, chronic alcoholic, then 1 point. Pulmonary artery involvement, another 1 point. Aspergillosis, 2 points. Malignancy, 2 points. Patient on mechanical ventilator, 2 points. And when you add them up and you chart out the score, if it is zero, the mortality is 1%. If the total score touches 7, then the mortality is almost 91%. So if there's a patient with, say, aspergillosis with a underlying chronic alcoholism and pulmonary involvement and lands up on the ventilator, so it's already 6 points. And if there is involvement of two or more quadrants, it touches 7 points. So 91% mortality expected in such a patient. So what will be your initial management while you're still exploring for the cause of the bleeding is securing the airways. So how do you secure the airways? If the patient has any gas abnormalities, gas exchange abnormalities, so you intubate the patient. But when you're intubating, please remember you should have a large bore ET tube, at least number 8 or above. Place the patient in recovery position. That is, the bleeding side should be down. If it is left side bleeding, then put the patient in the left lateral so that the left side is lower and the right side is up. Secure a large bore peripheral cannula or a central cannula so that you can push in IV bolus fluids in case the patient develops any hemodynamic instability, and monitor the patient for hemodynamics and gas exchange. So airway, because we need to provide suction. Breathing, we need to look at the oxygen levels, and circulation, we need to provide IV fluids like crystalloids, solutions, or blood products, depending on the extent of bleeding. So ABC needs to be taken care of like in any other patient. Also, you should take history of patients being on anticoagulants. So you may want to reverse it with the use of PCCs or direct reversal inhibitors if they're available, use of nebulized or IV tranexamic acid, FFP if INR is more than 2, cryoprecipitates or fibrinogen correction if fibrinogen is less than 2 or suspected, replace platelets if less than 50,000, and consider DDAVP in uremic patients. Then RBC transfusion if the hemoglobin is below 7 or a drop of more than 2 grams in the last 24 hours. So keeping all this in mind, these are the various steps that you need to cover in the initial manner of the patient, initial stabilization, while you're working up the patient to find out the cause and then, of course, treat the cause. A common pitfall is that if the patient is supposing, if you're thinking that the patient has pulmonary embolism, you may want to, initially think that you want to reverse the coagulopathy or administer TXA. In acutely life-threatening hemoptysis, always reverse any coagulopathy. Forget about the pulmonary embolism at present, but what is important is to control it with the use of IV tranexamic acid. And then we can do the anticoagulation later on. Tranexamic acid does not have many studies. It's basically a lysine derivative that inhibits fibrinolysis through the blockage of lysine binding sites on the plasminogen. Traditionally, it has been used to diminish blood loss following trauma in the treatment of heavy vaginal bleeding and in perioperative management of major surgeries. There are only limited number of trials that have been studied in the efficacy of administration in hemoptysis, and existing evidence appears consistent that it does result in reduction in the bleeding quantity as well as in duration. So it can be given in the inhaled form, nebulized form, 500 milligram to 1000 mg. It's physiologically sound to deliver it to lungs via inhalation. There's a small RCT that was conducted in 2018 that found patients receiving inhaled or nebulized tranexamic acid had greater resolution in first 5 days of admission compared to placebo for patients with non-massive hemoptysis. Start with 500 mg TID nebulized and consider it for 1 gram for massive hemoptysis, as this dose has been shown to shown promising results in case reports. Tranexamic acid, you can go up till 1 to 2 grams if you're giving IV, although we only give it up till 500 milligram, but you can go up till 1 to 2 grams. And RCTs have demonstrated a definite benefit in the management of non-massive hemoptysis again. Although there's a lack of evidence in massive hemoptysis, it is the preferred route of administration in patients who cannot tolerate a nebulizer or cannot adequately clear blood from their airway. So nebulized tranexamic acid, 1 gram for all hemoptysis patients with spontaneous respiration who do not have contraindication to tranexamic acid should be given. Now, what is important is after initial stabilization that you think in your own mind that what could be causing this bleeding and where has this bleeding started from. So for that, we need to understand the pathophysiology of bleeding. Please remember that the lungs have two kinds of circulation, the bronchial artery circulation and the pulmonary artery circulation. The pulmonary artery is majorly the cause only in about 10% of the cases, whereas bronchial artery circulation is the source of bleeding in 90% of the cases. Bronchial artery basically has systemic pressures, therefore the bleeding is more. The bronchi, the vagus nerve, posterior mediastinum, and esophagus, all you can see in this picture here. And it is at the T5, T6 level that the right bronchial artery and the left bronchial artery actually emerge. And from the aortic arch, there is this aortic arch is present at T4, T5 sternal angle, and then the bronchial arteries that emerge from the aorta directly. So they definitely are the arterial blood supplies at a systemic pressure. So the pressure is definitely higher, the bleeding is more, and it happens in nearly 90% of the cases. That is the bronchial artery which is responsible for the bleed. Pulmonary arterial system are basically from the right ventricle. It's a low pressure system. The pressure usually 8 to 25 mm. So there it would be a slower kind of a bleed, not as massive. After having determined the magnitude, it's important to now recollect all the basic causes that could be causing the bleeding. So it could start from the tracheobronchial tree, which could be acute tracheobronchitis, chronic bronchitis, bronchiectasis, which is more commonly presence of foreign body, tracheoesophageal fistulas, broncholithesis, bronchotelangiectasis, endobronchial growths. They could all cause bleeding. Out of these, bronchiectasis and endobronchial growths, bronchial telangiectasias are the ones which would cause major hemoptysis. Rest would not usually cause so much of hemoptysis. From the airways, then we move on to the parenchymal diseases, which could be the lung abscess, tuberculosis, pneumonias, fungal, parasitic, and other diseases. There could be intraalveolar hemorrhages, neoplasms like adenomas, hematomas, primary, secondary cancers, and congenital diseases that could result in hemoptysis. Pulmonary vascular diseases are the third most common cause of bleeding, thromboembolism, infarction, AV malformations, aneurysms, so on and so forth. Not to forget that the bleeding could also be because of cardiovascular diseases like the LVF, mitral stenosis, SVC syndrome, subclavian artery aneurysm, post-MI, congenital heart disease, CABG, CAG. They could all result in hemoptysis. Apart from that, there are various other hematological diseases like coagulopathy, DIC, leukemia, thrombocytopenia, use of drugs and toxins, trauma, and of course, iatrogenic when you're doing a bronchoscopy, especially when you're performing a bronchoscopic biopsy, while intubation, during surgeries, patients with amyloidosis, endometriosis, pneumoconiosis, aspiration, they all could result in hemoptysis. And then ultimately, when you find no cause, you just label it as idiopathic. Endometriosis is one cause that could occur in females at the time of their periods. So as they bleed during their periods, they could also have bleeding in hemoptysis from the lungs. There's a simple mnemonic that could help you remember the causes, which is called the battle camp: bronchitis, aspergilloma, tuberculosis, tracheal innominate fistula, lung cancer, pulmonary embolism, use of cocaine, coagulopathy, catamenial or endometrial cystic fibrosis, then autoimmune, alveolar hemorrhage, mitral stenosis, pneumonia, paragoniosis, and others. So these are the basic causes that you can remember. Battle camp is a simple mnemonic for you to remember the various causes of hemoptysis. In studies conducted in the Western world, the common causes were bronchiectasis, tuberculosis, bronchogenic carcinomas, aspergillomas, pneumonias. But in India, it continues to be tuberculosis, bronchiectasis, lung abscess, aspergilloma as the most common causes of hemoptysis, followed by lung malignancies and AV malformations. In children, hemoptysis is usually rare and may go unnoticed, but it's important to differentiate from pseudohemoptysis. It's considered to be massive when it is more than 8 ml per kg in 24 hours. The common causes are infections, tracheobronchitis, foreign body aspiration, pulmonary vascular anomalies, congenital heart disease, idiopathic pulmonary hemocentorosis, and cystic fibrosis. So you start with a basic workup in these patients with a CBC, coagulation profile, LFT, RFT. Deranged LFTs could contribute to bleeding. Uremia could contribute to bleeding. ECG, ABG, and of course, a chest X-ray. Apart from that, it's important to get their blood cultures, blood type cross-matched, use of BNP to look for CHF, echocardiography to see if there's any cardiac cause or pulmonary hypertension that could be causing it. As advanced testing, you could also do all the immunological markers like ANCA, ANA if you're not finding any other cause, inflammatory markers to see if there's any kind of inflammation, and spirometry, sputum cytology, sputum tests could be done for malignancies and infectious causes. But if it is a major hemoptysis that's happening, then spirometry would actually be a contraindication. I mean, cannot be performed because of the massive hemoptysis that is going on. So after having seen the cause of bleeding, and also you would require radiology like X-ray and CT scans to identify the cause of bleeding. But what is also important is now to identify the site of bleeding, that where is it bleeding from. So chest X-ray would help you identify the site of bleeding in 33 to 82% of the cases. It would also give you an idea of the underlying cause in nearly 35% of the cases, and it would rarely be normal. And I'll come to that as well later on. CT scan, of course, is superior to chest X-ray. It gives you correct localization in nearly 70 to 88.5% of the cases, and especially with these multi-detector CT scans with bronchial and non-bronchial systemic arteries being highlighted very well now. It can not only localize the cause, but also guide you when you're doing a bronchoscopy in these patients. And especially now with angiography that can be performed with the CT scan, you can actually identify even the AV malformations, smaller bronchiectatic areas, delineating the extent of neoplasm, and any other unsuspected abnormalities could also show up. And it will provide you a roadmap for bronchoscopy as well, in which segment to go and what would you expect before going in for a direct bronchoscopy. So this is the CT angiography of the chest, which is showing pathological left bronchial artery that originates from the anterior wall of the descending thoracic aorta. And this is the one which is showing you a pathological right bronchial artery that originates from the anteromedial aspect of the thoracic aorta, and hypertrophic left bronchial artery in the aortopulmonary window, which is again abnormal here in this situation. Now, what are the clues to bronchial artery as a source of bleeding? So when you see an angiography, you see vascular hypertrophy as is visible here, parenchymal hypervascularity, aneurysms that could be causing the bleed, then neovascularization, the identification of extravasated dye, which is relatively infrequent, and the visualization of bronchopulmonary shunting. That would also give you an idea that where is the patient bleeding from. Then we as pulmonologists always believe in early bronchoscopy because it's able to differentiate from pseudohemoptysis. It determines the site if it's a bilateral disease. It helps to isolate and protect the non-bleeding lung. And it could be diagnostic in high risk for endobronchial malignancy group, which basically includes those who are more than 50 years in age, chronic smokers with more than 40 pack years, and males. So if there's suspicion of endobronchial malignancy, which may not get picked up on the CT scan or even on angiography, bronchoscopy would be diagnostic in this situation. And of course, it has the advantage of being converted into therapeutic as well, because there are various bronchoscopic maneuvers or bronchoscopic strategies that you can follow during while doing the bronchoscopy and convert a diagnostic bronchoscopy into a therapeutic bronchoscopy. When it comes to that, then is the discussion and the debate that whether it should be a rigid bronchoscopy or a flexible bronchoscopy. Well, we as pulmonologists always prefer flexible bronchoscopy because it has advantages. It can be done at the bedside of the patient. It can, access right up to the distal orifices. You can do a lavage, and it's all done under topical anesthesia with a little bit of sedation. On the other hand, rigid bronchoscopy has its own advantages, like provides a larger lumen and improved suctioning capabilities. It's better clearance, improved visualization, but only up till the major bronchi, not to the distal bronchi, and it's continuously opening for the airway so that there's proper ventilation that is maintained. But the problem with rigid is that it requires a general anesthesia, OT, patient to be completely paralyzed, sedated, and poor visibility of the peripheral lesions and the upper lobes. Whereas flexible does not have those kind of disadvantages, except that it could have some poor suctioning and the airway patency is not as good. But if you conduct a survey amongst the pulmonologists, you would see that 79% would vote for performing a flexible bronchoscopy and early on in the disease, and also carry out endobronchial therapies to control the bleeding so that the massive hemoptysis can actually be brought under control as quickly as possible. But one thing I'd like to say that even with a normal X-ray, if you're performing a bronchoscopy, please be wary as sometimes you could land up in major problem. I'm sorry, some technical glitch for which it is not playing. But this is a patient where we saw a chest X-ray which was completely normal, and when we did the bronchoscopy, it started to bleed profusely from inside, and of course, it became a challenge for us to control it immediately. So you have to be mentally prepared for the therapeutic interventions that you may want to perform when you're going in for a bronchoscopy. So you have to be mentally prepared for all this, not just mentally, but also have everything ready with you. So first of all, what will be the indication of endotracheal intubation for massive hemoptysis? If the patient is tiring out, inability to clear secretions with coughing, if there's signs of respiratory distress, including hypoxemia or dyspnea, and too unstable to allow safe transportation to CT scan or intervention radiology. So which method is to be used for intubation? Endotracheal intubation via the conventional RSI and the standard video laryngoscope is the airway strategy of choice for patients with massive hemoptysis. As I said in the beginning also that you should use a large bore endotracheal tube, and adequate suctioning should be possible as that will be critical to clear the airways of all the blood that is getting accumulated inside. And 8 plus tube would also allow the bronchoscope to go inside easily. Of course, with the smaller tubes, you could use a pediatric bronchoscope, but the channel in pediatric bronchoscope is not big enough to allow adequate suctioning. Therefore, you use a larger bore tube so that adult bronchoscope can go inside and you can do the suctioning properly. And even if you have to perform certain endobronchial techniques, then again, larger endotracheal tube would be preferred. If RSI is not possible, then ketamine facilitated awake intubation can be considered in these patients, especially if they have an intact cough reflex and adequate respiratory effort. Topicalized awake intubation with lidocaine should not be used as it will likely be ineffective due to the volume of blood expulsion or result in elimination of the cough reflex. Patient positioning is also very important. As soon as the patient is intubated, it's better to keep them at a 30 to 45 degrees, or if you know which side is the bleeding, then you put them in that lateral position. So, main stem bronchus intubation for massive unilateral hemoptysis, what you do? If you don't have the bronchoscope or bronchoscope is taking time to come, you still want to secure the bleeding inside. So, you would want to isolate the other lung, the non-bleeding lung, from the bleeding lung so that the blood spillover does not happen from one side to the other. So, what do? You intubate the patient, slide in the tube, just by naturally when you're pushing the tube in, because of the angle is such that it usually slips into the right main bronchus. So when it goes into the right main bronchus, if the bleeding is still continuing, then that means that the patient is bleeding from the right side. You pull the tube, put in a bougie into it, rotate it 90 degrees in the anti-clockwise direction, and it would automatically slip to the left side and then push it in. Now is the time when you should be able to block the right side completely. So you've isolated the bleeding side and the tube is now into the left main bronchus. So you can perform a single lung ventilation in this situation. And when you're doing a single lung ventilation, you need to adjust the tidal volumes by this formula, normal tidal volume minus 100 ml divided by 2 plus 100 ml. So it has to be lesser than the usual volume. So if you think 400 ml is the tidal volume that you would be or 500 ml is the tidal volume that you would be using, then 500 ml minus 100 ml, that means 400 ml divided by 200 ml plus 100 ml, that means 300 ml would be the tidal volume that you would want to give to this patient. Positioning of the patient is very, very important, as I've been saying. If it is bleeding from the left side, then you keep the left side down and the right side up. So lateral decubitus position should be kept in the patient. Now you need to understand that what are the various non-surgical measures that can be taken to control the bleeding. There are the bronchoscopic measures, then the bronchial artery embolization. And then, of course, if nothing else works, then surgery is the option, but that's the later option. We would first focus on the bronchoscopic measures that can be performed to control this bleeding. Again, there are various measures that you can take: bronchial irrigation, use of vasoconstrictive agents, lasers, thermal therapies, balloon tamponading, double lumen endotracheal tube, unilateral lung ventilation, and endobronchial techniques. So first and foremost, the easiest thing that's available, the cheapest option is cold saline lavage, where you use a normal saline at 4 degrees centigrade. 50 ml aliquots are used, and it's pushed into the through the bronchoscope into the segment that is causing from where you see the blood coming out. For this situation, rigid scope may be better over flexible bronchoscopy, but we prefer flexible bronchoscopy only. Then you could use topical epinephrine 1:20,000 dilution. It's effective in mild to moderate, but not very helpful when it's massive hemoptysis because the blood is already in the airways. The more you keep clearing it, the more blood keeps coming from behind. So even if you're instilling epinephrine, it won't go very deep. It will just be on the surface of the blood itself. And also that epinephrine has been seen to be associated with tachyarrhythmias, ventricular tachycardias, VFs, atrial arrhythmias. So therefore, it is now being avoided to be used in this situation. Tranexamic acid, besides giving IV nebulized form, you can even just instill it locally into the bronchoscope to be given endobronchially 500 to 1 milligram, and the response time is usually in seconds. Fibrinogen, thrombin are other options that you can apply locally, and they would also result in the arrest of bleeding immediately. Now comes tamponading. So what do you understand by tamponading? Tamponading is stoppage of the flow of blood by pressure, as by a tampoon or a pressure dressing applied to stop a bleeding. Procedure will depend upon the site of bleeding, and I'll just come to that. So if the patient, first thing that you can do is a double human endobronchial tube can be used for tamponading. That basically means that it's a double human tube with one bulb going into the left main bronchus and the other side being open. So this is left in the port is left in the trachea so that the ventilation can happen in both the tubes, but both the lungs have now been isolated from each other. So if the bleeding is from the left side, it won't spill over to the right side, or if it is on the right side, it won't spill over to the left side. So it provides you independent bleeding. But then manipulating this tube is not so easy. Now, if the patient is bleeding from right side, then you need to basically isolate the right side, as I said, and intubate the patient on the left side. As you can see on this video, I wonder why this video is not playing. Just if you people just give me a minute, I just see if I can do it from my laptop because on the laptop it was definitely working. I'll just see. In the meantime, we continue with this. So this is basically you're trying to push the endotracheal tube into the left main bronchus. Again, this is called selective intubation and protection of the lung. Of the other lung from the blood. If it is bleeding from the left side, then it becomes a little tricky, primarily because there's a right upper lobe opening right at the about 2 centimeters away from the carina. So if your endotracheal tube slips into this, it may just block and cause further decompensation of the patient because you've taken away the source of, taken away about 30% of the lung, which, even otherwise you're only on a single lung ventilation. So that is why in this situation, what you do is you use an occlusion catheter, which goes into the left main bronchus and keep the endotracheal tube in the trachea itself, the lower end of trachea. I'm trying to open it on the other side. Dr. Tapesh, I'm not able to open the Zoom link again.
So, how can I help you, sir? Stressing it again or what?
I'm not sure. Yeah. Why is it not
कोई बात
opening?
नहीं
Is it
सर,
only that it'll open once?
नहीं ऐसा नहीं है, ऐसा नहीं. I'll send it again if you want.
I'll just see. Achha, anyway, let's just continue with this in the meantime. There's something wrong with the system here, probably. None of the videos are working.
It's okay, sir. Don't make so much.
Okay. Chalo. So basically what you do is so if not this, then otherwise what you can do is with the conventional endotracheal tube only, you gradually advance it into the right main bronchus and leave the bulb here in the just before the opening of the right upper lobe bronchus. So that the distal end of the ET tube is probably beyond that, but bulb is here in this area, which is about 2 centimeters area that you can use. This was a patient in whom we had massive hemoptysis with because of a right upper lobe, left upper lobe aspergilloma. The patient started to bleed like crazy. We did not have anything. The patient had been on ventilator for a very long time. I did not have access to any kind of equipment that was available. So all I had was a Foley's catheter with me. So what I did was I put in the guide wire through the tracheostomy. Patient was luckily on a tracheostomy. I put in a guide wire, put a through the tracheostomy, and then threaded the Foley's catheter over the guide wire and controlled the bleeding. You can see a Foley's catheter going in. The Foley's catheter was then inflated and the bleeding could be stopped. Otherwise, this was a massive hemoptysis that the patient had been on ventilator for some time, luckily tracheostomized, and the bleeding could be controlled with this Foley's catheter. So basically, the idea of showing you this was that anything that has a bulb can be used depending on the size. Then there are these various types of endobronchial balloons can be used. These are the older balloons that one can use. So if you see a bleeding coming in from a segmental bronchus, then what do? You do the bronchoscopy, identify the segment, introduce the guide wire over it through the bronchoscope, then pull out the bronchoscope. This is the older conventional techniques that we have used in our patients. After the guide wire has been, the bronchoscope has been pulled out, then you put in the balloon over the guide wire and then pull the guide wire out. And all this happens then under bronchoscopic visualization, as I just showed. So you can see the guide wire was there. Now over the guide wire, this balloon has been threaded over it and inflated in the segment to control the bleeding. You can see the catheter, the balloon that was used. This is in the left upper lobe, which can be seen. But the issue is that it can also cause pressure necrosis. So you have to be sure of how much pressure is to be filled in the balloon, how much air is being filled out. The bronchoscope itself can be used for tamponading the blood sometimes, especially when you're performing a bronchoscopic biopsy, transbronchial biopsy, and patient starts to bleed. So what do? You just push the bronchoscope in the same segment and leave it there for 4 minutes without doing anything. Of course, if you have access to cold saline, then you push in cold saline and it will control the bleeding. But what is important is that use the same bronchoscope for tamponading the area from where the blood is coming. In fact, what I always say is that when you're doing a bronchoscopic biopsy, then what is important is that do not lose sight of the segment after the biopsy. What people do sometimes is they take a biopsy and pull out the scope as well as the biopsy forceps and leave that segment. And if it starts to bleed, then you can't go back into the segment ever because you won't be able to find where that segment is. So the key is that when you take a biopsy, you push the scope inside while you're pulling out the biopsy forceps. So when you push the scope inside, it will go into the same segment and tamponade it there, leave it there for 4 minutes till it stops completely. Another option is use of Fogarty's balloon, which is also being used quite commonly now. You could even use, earlier we even used the 11.5 mm retrieval balloon or a multi-catheter, multi-tipped catheter that we've used in the past. Especially the GI balloons have been used earlier. I'm talking about early 2000s when these bronchial balloons were not available. We would use it from our GI colleague. Then there are the double lumen bronchus blocking devices that are available, 6 French, 170 centimeters long, where balloon is inflated by a detachable valve at the proximal end. As I showed you in the other video also, when you're doing the ballooning over the guide wire, it is done in a blind fashion. And you have to withdraw the scope, then push the balloon over the guide wire. In this case, what you can do is the balloon is inflated by a detachable valve and bronchoscope can be removed without any modifications. Pulmonary artery catheter is also being used when it is a smaller segmental bleed. Arns blocker is something that now we are using very commonly. This is the Arns blocker, which has a loop at its distal end, one for suctioning and one is for adjusting the loop. This is the loop which is threaded over the bronchoscope. So you put the bronchoscope into this loop and then insert it into the patient's nostrils and into the airways. So you'll be able to see it here in this video where you're inserting the bronchoscope with the balloon across the vocal cords, the Ans blocker, sorry. This is the trachea. This is the carina there. You keep cleaning up the secretions along with carina, as you can see, and then you go into the right main bronchus. I mean, of course, this will also depend from where the bleeding is coming from. This has been introduced into the right main bronchus. This is the right upper lobe bronchus. You identify that because the bleeding is from lower down. So you push the balloon, the Ans blocker here now, release it from the bronchoscope, just loosen the grip and push it down. Now you can see the Ans blocker emerging here, and you put it in the desired segment and inflate it depending on the site and the size that you need to block, the size of the segmental bronchus that needs to be blocked. And you bring out the scope, leaving the Ans blocker behind. This is how the Ans blocker is introduced inside. So this has gone inside. Now this is then attached to a catheter, which can be used, which has a through which one the bronchial blocker is going, the other one through which the bronchoscope can be introduced, and third which is attached to the ventilator. Apart from that, you can even use silicone spigots, which can be placed endobronchially. They are very simple to use. This is a rigid bronchoscope that was performed, but you could even use it with the conventional bronchoscope where spigots are being introduced into the bronchus. So you hold it with the biopsy forceps, push it inside, go in with the bronchoscope, and block the segment from where the bleeding is coming. This is how you leave the spigot behind. The only disadvantage is the patient coughs vigorously, then these spigots can get dislodged and come out. We actually have been more innovative. Unfortunately, I haven't captured it here, but we've been using the Merosil. You know what Merosil is? Merosil is basically the it's a kind of a, I'll tell you what it is. It is a kind of a cellulose fabric that is used when you have epistaxis. So we just take smaller segments of it, break it into smaller pieces, and use that to block these bleeding segments. And it's actually been very effective. And we should be publishing the data and sharing with you the next time when we have a talk like this. People have also used fibrin and glue for this purpose. Identify the site and then just instill the glue. The glue will result in adhesion between the opening of the segments and block it completely. Oxidized regenerated cellulose is another novel knitted fabric that can be used for this purpose. It swells into a brownish or a black gelatinous mass. The maximum size is approximately 30 to 40 mm, and it can absorb without significant signs of visible foreign body reaction. This is how it is. You hold it with the bronchoscopic biopsy forceps and introduce it through the bronchoscope and go and push it in the segment that is bleeding. So post-obstructive pneumonia can occur in these kind of patients. The other devices that have been used are the endobronchial stents if it is a localized endobronchial bleeding. The usual complications of tamponading could be post-stenotic infection, pressure necrosis, coughing, hoarseness and granulation over vocal cords, and dislocation. Then there are neuro interventions that you can perform, but these are mainly for bleeding from endobronchial lesions where there is, whether it's bronchoscopic laser, electrocautery, argon plasma, or brachytherapy that can be carried out. So laser photocoagulation usually uses the ND-YAG laser. It's effective in bronchoscopically visible source. Photocoagulation of the bleeding mucosa with resulting hemoptysis can easily be achieved, and it also achieves photoresection and vaporization. APC machine, that is the argon plasma coagulation, can also be used for the same purpose, again only for those which are endoscopically visible. So in this, what you do is you basically APC spray is carried out in the area from where the blood is coming, and it would cause coagulation, devascularization, and carbonization at the site of bleeding. Once desired desiccation is done, then deeper penetration can be done to further tissue should be stopped. It's used for superficial and spreading lesions only. Electrocautery can also be used. It has a coagulation mode in the contact mode that can be used for this purpose. So electrocautery is the simplest and the cheapest device that can be used, and this is exactly what we use in our setup. It has coagulation mode as well. We use that. So then comes, if all these measures have failed, or these are your rescue measures with which you've been able to stabilize the bleeding, yet you need to do the curative procedure. The curative would be only two ways: bronchial artery embolization or surgery. Now, bronchial artery embolization has an immediate success rate of about 64 to 100%. Recurrent bleeding could occur in 16 to 46%, and there could be a technical failure in up to 13% of the cases. This is largely caused by non-bronchial artery collaterals from systemic vessels, such as the phrenic, intercostal, mammary, or subclavian arteries. So the indications would be in all those patients where surgical resection is not possible or is not recommended, or those who refuse surgery. Supposing somebody has a bilateral disease, then of course, surgery may not be an option. Supposing somebody has poor lung reserves, surgery may not be an option. So in those cases, bronchial artery embolization can be considered. But again, if it is bilateral fibrobronchiectatic diseases, then even bronchial artery embolization would only be a temporary measure, because sooner or later revascularization would occur in those cases. So you need to warn the patients that if it is a fibrocavitatory disease, then BAE would only be a temporary measure, because sooner or later there will be revascularization in that area. And again, the hemoptysis can occur. But when will it happen? Nobody can predict. It could be 6 months to 6 years or even longer. So with bronchial artery embolization, what do you do? Basically, you use a catheter and identify the site of bleeding and then embolize it using various particles. So this is the right intercostal bronchial artery, where which was the probable focus of bleeding and could be blocked with the blockers. And I'll tell you what all can be used for this purpose for embolization. This, as you can see, a common bronchial trunk, which is grossly tortuous, and you can even see the ooze here in this area. So these are the various catheters that I used. Forward-looking catheter, the Cobra, HIH, RC, 4 French, 5 French, 5.5 French that are routinely used. Most commonly used is a micro catheter with super selective catheterization, which is very essential. And you use different types of materials like absorbable gelatin sponge, gel foam, pledgets, thrombin, glue, and recently are the polyvinyl alcohol particles, the PVA particles that are used quite commonly now. So this is the pre-embolization bronchial angiogram that I was conducted to look at the abnormal circulation. You can see it here. And then post-embolization, now you see no bleed, no ooze, no abnormal circulation. This is a case of a bronchial artery aneurysm, where you can see bleeding that is happening from the aneurysm and a hypervascular lesion with the aneurysm. PVA particles were inserted. And then you see post-procedure, there's no hypervascular lesion and no aneurysm seen apparently. So superselective embolization of intercostal artery can also be done, as is seen in this case, pre-embolization and post-embolization, where the microvascular catheter was passed beyond the radicular artery and resulted in decreased vascularity once embolized. Left upper lobe bronchial artery, which was tortuous and hypertrophied vessel. This was before embolization. And then what happens after embolization, as you see, there is decreased vascularity and hypertrophy vessel. Now you can't see the hypertrophic vessel anymore. The acute complication of bronchial artery embolization that you need to be aware of are pleuritic chest pain, transient air embolization, radiographic pulmonary infarction, TIA, distal migration of the detachable balloon, DVT, stroke, reflux of embolization coil, arterial wall damage with potential perforation. But what is most important and that you should be wary of is transverse myelitis, neurological paraparesis, and this happens when the material goes into the posterior spinal artery. We've had one such patient, my own personal experience, where this was a young male who was actually preparing for the Asian Games boxing champion, and he came to us with hemoptysis. We went ahead, first we managed it conservatively. He was doing quite well. We planned to shift him out of the ICU. Just as we decided to shift him out of the ICU, we had a massive hemoptysis and we had to take him out for a bronchial artery embolization. And after bronchial artery embolization, which was done, 24 hours later, we realized, in fact, 12 hours later itself, we realized that the patient is not moving his lower limbs at all. So he developed complete paraplegia because of the embolization of the posterior spinal artery. We've also seen patients of developing stroke, CVAs, infarction because of the dislodgement of the particles or the PVA particles that were used for embolization. So these are something that you need to be very, very careful of, and the doctor, the clinician performing it needs to be very aware of this complication. Rebleeding can occur. It has two peaks that are seen in rebleeding after bronchial artery embolization. One occurs at 1 to 2 months, which results usually occur because of incomplete embolization of the bronchial arteries, and then 1 to 2 years where there is recanalization of the embolized arteries, as I said. The disadvantages are that it may not be available universally. There may be a lack of expertise, relying on indirect evidence like Rocho's vessels, increased caliber or aneurysmal dilatation, and inability to shift the patient to cath lab or radiology department. Surgery definitely is curative, 100% curative, but you need to be sure that the patient, one, it is a unilateral disease where it's preferred, and that the patient will be able to tolerate this radical surgery. Contraindication would be inadequate cardiorespiratory reserve, inoperable or disseminated lung cancer, extensive bilateral disease, and associated comorbid conditions. Even then, the surgical mortality ranges from 1 to 50% in different series. So, if it's a bronchial adenoma, aspergilloma, hydrated cyst, arterogenic pulmonary rupture, chest trauma, AV malformations, unresectable would be the indications, whereas rest all would be contraindications for surgery. In aspergilloma, people have also tried intracavitary installation of amphotericin B, but I'm not sure how much it would work. This is our case series that we presented in American College of Chest Physicians conference of 2002 to 2011, 72 patients. There were different age groups. The criteria was hemoptysis more than 300 ml in 12 hours. Early bronchoscopy was performed in all these patients, followed by bronchoscopic wedging and local installation of topical agents, which had failed to control the hemoptysis. So our experience showed that most of these patients underwent early bronchoscopy, bronchial tamponading, followed by bronchial artery embolization, and the success was fairly good. Only 3 patients required surgery, and all these 3 patients, uh, the surgery was successful. We performed EBBTs, EBGTs, and bronchial artery embolizations to control the bleeding in these patients. So to summarize it all, early bronchoscopy helps in identifying the site of bleeding and deciding the further course of management. Endobronchial tamponading serves as a rapid, simple, safe, and effective tool in controlling life-threatening hemoptysis. Bronchial artery embolization is becoming increasingly popular as a more definitive procedure when compared to surgery. And this is a flow chart that you should be following, where you do the initial evaluation of the patient with the vital signs, oxygenation, chest X-ray. If the patient is stable, then you go in for a CT scan. If the patient is not stable, then you probably perform a flexible bronchoscopy to localize the site of bleeding. If in the meantime the patient has stabilized, then you go in for a thoracic iodogram to confirm the site of bleeding and then probably embolize the patient. If not, then patient is not continue to bleed, then embolization should be considered. If it rebleeds, then again embolization or surgery, or definitive would be definitely be surgery that has to be considered. So with those words, I'd like to thank you all for a very patient hearing, and I'll be happy to take any questions that you have.
Thank you, Dr. Nagia, sir. Can you stop the share screen, sir?
Yeah, just doing that.
Thank you so much for a wonderful talk, very detailed and very nice. Any questions are there from the audience? We'll be happy to take them. So far, there are no questions. So, friends, just a couple of things. Sir has already told everything. One, treatment is mainly bronchoscopic, whether you can actually identify and do some local treatment with the help of a bronchoscope. At times, you need bronchoscopic artery embolization. And very important from intensive care point of view is that involve the pulmonologist early. It's really the pulmonologist domain who can control the bleeding and who can do all these things. So that is very important. Get the consultation in early. So I think, sir, there are no questions from the audience. I thank you once again for contributing to our sessions. I think this is the fourth talk you have taken on a session. Really grateful to you. Thank you so much, sir. Soon we'll share it on our YouTube
Very
channel.
much pleasure. Thank you so much, Avesh, for having me here.
Bye bye, sir.